Morning, everyone. Thank you for joining us for this AOCMF live session. We have a great setup of speakers this morning to discuss frontal sinus as well as NOE injuries. My name is Salam Salman, and I'll be moderating for these two presentations that we'll be having shortly. A couple slides here. The first thing is just disclosures and nothing pertinent pertaining to this topic. So first up, we have Dr. Jessica Lighthall, who's an associate professor in the Division of Otolaryngology, Head and Neck Surgery. Also Director of Facial Plastic and Reconstructive Surgery at Penn State University. She obtained her medical training as well as residency at OHSU in Portland, followed by a fellowship in facial plastic and reconstructive surgery in Minnesota. Her practice involves treating aesthetic concerns of patients as well as recon of the head and neck cancer defects, as well as facial skin cancer defects and traumatic injuries and congenital deformities. She'll be talking today on the management of frontal sinus fractures. And with that, I'll hand it over to you.
Okay, thank you for that nice introduction. So as we know, for these webinars, we're trying to fit as much information into a 30-minute block. We'll answer questions at the end, and Dr. Salman will be answering them in the Q&A session if you have any during. We're going to kind of breeze through a little bit, and I'm really going to just focus on kind of the evolving paradigms for treatment of frontal sinus fractures. Learning objectives are today, we will discuss some epidemiology and the evaluations of patients with frontal sinus fractures, and we'll kind of review some of the more traditional paradigms for treatment of these fractures. But really, I want to incorporate more of the conservative approaches to frontal sinus fractures and the evolving trends. This is really a rapidly evolving paradigm here. Very briefly, frontal sinus is not present at birth. We do have some pneumatization of the middle meatus during gestation, but really we don't start getting more pneumatization until around 1 to 2 years of age. And the frontal sinuses are clinically and radiographically visible around 7 to 8 years of age. By around 12 to 15 years, they're essentially adult size, although there will be a little bit further growth of the frontal sinus. These are scallop sinuses. Asymmetry is more of the rule than the exception for these sinuses. There's usually an intersinus septum, at least one. And as we know, there are some pretty critical structures that are being protected by the frontal sinus, which acts as an airbag. The anterior table is very thick, can be up to 12 millimeters in some individuals, and the posterior table is much thinner, anywhere from 0.1 to 4 millimeters. And there are some vascular connections through the anterior cranial fossa. The floor of the frontal sinus is the orbital roof and the anterior ethmoid air cells, and the frontal sinus outflow tract is typically medial, inferior, and posteriorly placed within the sinus on each side. The frontal sinus outflow tract is shaped like an hourglass. Superiorly, you have the infundibulum. The narrowest portion is at the ostia, which is anywhere from 1 to 4 millimeters, depending on the patient's specific anatomy, and drains into the frontal recess. Medially, it's bounded by the middle turbinate, laterally by the orbit, anteriorly by the Algernazzi cell, and then more posteriorly, that's a little bit variable based on the patient's specific anatomy and pattern. This is off the AO website. A lot of my illustrations are, which kind of just shows this in a sagittal CT scan. This is a really critical area to evaluate when you're looking at patients with frontal sinus fractures. So about 5 to 15% of patients with maxillofacial fractures will have a frontal sinus fracture. They're not very common, as you can see here. About 2/3 are male, and these are very high energy impacts, high velocity impacts. So if you're thinking about mechanism of injury, we're thinking about motor vehicle collisions, significant falls, projectiles, things like that that will cause these type of injuries, these high velocity ones. Because of the high impact type of mechanism, most patients, about 3/4, will have associated injuries, including loss of consciousness. About 1/3 will have a CSF leak, intracranial injuries, but also other facial fractures, spine injuries, and extremity injuries. Critical in the evaluation, particularly due to the typical mechanisms of injury and the high energy, is to make sure the patient's stable. We all know our ABCs, and to do an overall trauma surgery to rule out more serious injuries aside from facial fractures first. Once patients are stabilized and you're beginning your more focused trauma, if the patient is conscious and able to talk to you, they may complain of pain, headache, paresthesias or numbness in the forehead, vision loss, rhinorrhea, and commonly you can see multiple lacerations like you see in this patient. Often you can see exposed bone or brain, and even CSF draining through some of these lacerations. They may have significant edema and hematomas, which can obscure contour deformities like you see here. Those may not become evident until later. You may visualize rhinorrhea, but sometimes that's difficult to assess as they often have epistaxis and other signs that you see. If you are unclear if they have a CSF leak or not, you can send some confirmatory tests such as the halo test or beta-2 transferrin to confirm this. Historically, we use x-rays in the Waters view. Those really aren't utilized much anymore now that we have high resolution CT. This is really the workhorse for evaluation and the gold standard for diagnosis with axial, coronal, and sagittal views. If you have the ability to get 3D reconstructions, especially for complex injuries, I think this really gives you some additional three-dimensional information for surgical planning. And many of these patients have other facial fractures, so they can help with your overall maxillofacial reconstruction. You can see on the axial views, this gives you a really nice view of the anterior and posterior tables, the degree of comminution and displacement. And the coronal and sagittal views will also give you that information, but they will also allow you to assess your frontal sinus outflow tract. You can see that here. AO classification for frontal sinus fractures is really not very complex. You can have an anterior table fracture, which is isolated. This can occur in up to 25 to 20% of fracture cases. Isolated posterior wall fractures are extremely rare, 2 to 7% of frontal sinus fractures. Typically, they're combined with other walls, or your frontal sinus outflow tract injuries. Again, these are typically not isolated. There's usually other walls fractured. Really critical for this and helping you decide how to treat these patients, which isn't involved in the classification, is how much displacement and comminution and what's involved. And is that frontal sinus drainage pathway obstructed or is it patent? So many different treatment options are discussed, and we'll kind of go through some of the changing paradigms. You can elect to observe and select cases and just do serial imaging. If, for instance, an anterior table fracture, you can do delayed camouflage if it becomes a cosmetic issue. You may elect to acutely perform open reduction internal fixation, obliterate, cranialize the sinus, and those are kind of the classic techniques. And in the last 10 to 15 years, endoscopic assisted approaches or even endoscopic transnasal repairs have really gained a lot of popularity, and we'll discuss that today. There's still a lot of controversy about which patients require acute intervention or even delayed intervention, but most agree that if you have significant comminution or displacement of anterior or posterior table fractures, if you have significant displacement of the orbital roof or rims, a persistent CSF leak, or significant injury to the frontal sinus outflow tract, that really will require some surgical interventions. So the goals of reconstruction, like most of our maxillofacial reconstruction, is to perform an anatomic reduction, restore contour. This is non-load bearing, so various techniques for fixation apply, such as mini plates, mesh, wires, and our main goal is to create a functional or a safe sinus that adequately drains in order to minimize the acute and delayed complications that can occur from these fractures. Traditional access is from a coronal approach. Regardless of how you design your incision, this gives excellent visualization and access to the entire frontal sinus, orbital rims, NOE regions for any approach that you're utilizing. There is up to a 17% or higher rate of complications from this, including headache, paresthesias, frontal branch paralysis, alopecia. So there has been a move towards using more minimally invasive approaches. Clearly, if they have a big laceration, as you see here, that's a nice way to access. But the move towards minimally invasive and more cosmetic approaches can be from a superbrow approach, like I've marked out here. It can be an infrabrow or a bluff incision, brow lift approaches, and using endoscopic guidance for any of these approaches to really optimize your results is a great option. And then the transnasal endoscopic approach, where everything is treated through the nose with scopes. This is really gaining a lot of popularity and shown to be safe in multiple different literature with multiple different areas. I think the key with this, though, is that it does require you to have experience and comfort using endoscopes and performing a transnasal approach, or have a colleague that is comfortable with this that you can involve in the patient's care. So for anterior wall fractures, there's still no hard and fast rules about when to fix these and who's going to have a cosmetic deformity. There's very rarely functional deficits with this. And initially it can be difficult to say how much deformity you're going to have. Several studies have looked at the degree of displacement and what may be a clinically significant depression for the patient later on. And in general, that cutting point is around 4 millimeters, so that if a fracture is less than 4 millimeters, generally you can observe these. If for some reason they develop a deformity, you can perform a delayed camouflage procedure with fillers, fat, custom implants, or bone cement, kind of your camouflage of choice. If there's intermediate displacement of 4 to 6 millimeters, options tend to be open reduction in internal fixation, or observe and camouflage if it becomes significant for that patient. With displacement of more than 6 millimeters or severe comminution, typically we're going to try to repair these. This is usually an open approach. It can be endoscopic assisted through any of those transcutaneous approaches. And recently the transnasal endoscopic indications have really expanded to also involve anterior table fractures. You can get excellent access, and with improvement in navigation as well as overall improvement in instrumentation, you can reduce these fractures all through the nose, and you can place external splint if necessary. You can also pack the sinus and place stents and then remove those once adequate healing time has occurred. So here's just an example of a patient with anterior wall fractures in the nasal root. You can see from this 3D scan, they also have significant other fractures that we're going to be treating. One thing to mention is often with these anterior table fractures, you get this high force of impact, and it can be difficult to actually reduce those fragments. They're kind of stuck. Ways to work around that is using a screw for the fragments to reduce them. You can perform a trephination type of an approach, or you can do transnasal assistance and reduce them through the nose. Any of those are reasonable options. In this case, this gentleman had a large laceration, so we just placed some mini plates and reduced that, and then went on to treat the rest of his fractures. One note with him, we did use intraoperative CT scan. If you have this available, it's a nice adjunct. I don't use it for all the cases, but with him, he had multiple other facial fractures, so we were already using it. When the fractures involve the frontal sinus outflow tract, traditionally, that's not considered a safe sinus. So the recommendations are to either obliterate or cranialize the sinus. So taking the sinus out of the equation and trying to minimize more long-term complications. But this has been evolving. If there are minimally displaced fractures, you kind of just observe them. If they're mild to moderately displaced, even if there's partial obstruction of the frontal sinus outflow tract, however, it's still patent, you can just observe these and perform repeat scans. If the sinus spontaneously ventilates, and literature has shown that if you observe these, 75 to 80% of them will spontaneously ventilate, then you can just continue to observe them with serial imaging. However, if that sinus becomes obstructed and opacified, then performing endoscopic sinus surgery will help open that. If you have a completely obstructed outflow tract, that's not going to be a safe sinus, and you should be obliterating, or with kind of the new rules of our transnasal endoscopic approaches, you can actually treat this and open up the frontal sinus outflow tract through the nose. Again, this does require a lot of expertise. You may not have that available at your institution or be comfortable yourself, and those are significant considerations. For severe fractures that involve the frontal sinus outflow tract with complete obstruction and posterior table injuries, cranialization is still a recommendation. So here's just a patient with some anterior table fractures, as well as having some significant NOE fractures, medial orbital wall, and some partial involvement of the frontal sinus outflow tract, but not complete obstruction. And for cases like this, you know, here again, here's his 3D image. You can kind of see the outline of the fast pitch softball that hit him. But for this one, we elected to open him up and repair and reduce these. In this case, I used mesh plate. Again, I don't think it matters so much as long as you're creating an adequate reduction in contour. And then here's him 2 years later. We did nothing for that frontal sinus outflow tract. He's ventilated and has a nice, safe, open sinus. If you're going to obliterate, classically, you're going to outline the sinus. This is done in multiple ways in order to completely remove that anterior table, but leave the posterior table intact. You can do this with transillumination through either a trephination or through removed fractured segments. You can do this using a map from an x-ray, and you can do it with navigation. The really key tenets are to remove all mucosa from the anterior and posterior table, including drilling out you know, the nooks and crannies of the sinus. There's no trapped epithelium. And then you're going to invert sinus mucosa at the frontal sinus outflow tract to occlude that. And then you're going to fill the cavity and get rid of that sinus. There's multiple different materials that you can use for that. Discussion of that's beyond the scope of this. But whether it's fat, fascia, pericranium, you're going to completely occlude that sinus. And then you're going to replace your bone flap and reduce all your fractured segments. Here's just a picture from Dr. Strong from the AO website with the unilateral cranialization, unilateral obliteration right prior to the anterior bone flap being replaced. For posterior table fractures, traditionally we're taught that if there's displacement of 2 millimeters or 1 table width, and I remember this during my residency, then you should obliterate or cranialize. That's really evolved significantly. And now if there's mild to moderate displacement, but no CSF leak, you can just observe and perform serial imaging. If the sinus becomes opacified, then potential endonasal repair or obliterations are good options. If there is a CSF leak, you can observe for a while, and if it's persistent, then you can proceed with either endonasal repair and cranialization. The literature is a little bit split on how long is okay to observe, but up to 2 weeks tends to be pretty safe. If it persists, despite conservative measures, then cranialize if you don't have the ability to do endonasal repair. And if you do, performing transnasal repair is a nice option. If you're observing a leak and it resolves, then you go back to the observation and serial imaging paradigm. Still, for severely displaced comminuted posterior table fractures, the recommendation is still for cranialization. So cranialization similarly involves removing that anterior table first, removing all sinus mucosa and drilling, and then removing the posterior table. In my practice, I don't typically outline the sinus. I just do a large craniotomy, remove all the posterior wall. I think the key is that you are confirming that the entire posterior wall is removed and you've completely removed all sinus mucosa and gotten rid of all epithelium with drilling. Once that happens and you've removed that, you're similarly going to invert your sinus mucosa into the outflow tract and then occlude this with fat, fascia, bone, whatever material you choose. Oftentimes you can also use a pericranial flap and fold this in. Here's just an example, and to note some of these fractures, even if they don't have skin lacerations, the pedicles can be a little bit tenuous with these high impact. You can see in this flap there's partial ischemia on the left side, but this was still an adequate flap for us to use in this patient with significant CSF leak. One key note with that is if you are going to be doing this, you do need to leave a small gap for your flap unless you can pass it more inferiorly through some comminution. Don't make too big of a gap here or you can have a contour deformity. This is also a nice approach using pericranium folded in to treat other anterior skull-based CSF leaks. So really endoscopic treatment has gained significant popularity in the last 10 to 15 years. First through more transcutaneous endoscopic assisted approaches from endoscopic brow lift or the super sub brows, etc. Trephination I'm showing you on the right side from the AO website. That's just a nice way to visualize and assess your sinus. You can see a CSF leak, you can see your fracture segments. You can also reduce fractures, you know, through these small entries into the sinus. But really where the kind of controversy and the more conservative approach is moving is towards transnasal endoscopic approaches. In order to do that, you're going to do a frontal sinusotomy. So again, this does require some surgeon training and experience, and you have to be comfortable doing these more extended procedures. You have to, at a minimum, do a draft 2A. You can extend this into a draft 2B and draft 3, depending on the amount of exposure you need and access you need for the severity of the fractures. You can reduce these fragments and either pack the sinus and then remove them later once they've had time to heal. You can place an external splint, or you can use some transcutaneous screw placement if you need to. You can remove fragments. You can get great visualization of CSF leaks and repair these with underlay or overlay grafts. And typically you're going to stent the outflow. Research has shown really great results with this, with very low need for revision rates and revision surgery. And the indications for which patients are appropriate for this is really expanding as we gain improved advanced rhinologic skills and skull-based skills. Revision rates can be less than 5% for needing this, as well as really good repair of CSF leaks with low rates of recurrent CSF leaks. I just took a look, and even in the last 5 to 6 months, there's already, I think, 3 or 4 publications on this expanding role of endoscopic treatment. So I think this is mostly where a lot of the treatment patterns are going. A brief note on adjuncts to surgery. We use image guidance for many different indications and for sinus surgery, but it's also great for severe fractures and just used during surgery to confirm that you are happy with your reduction. I often will do, for very complex fractures, virtual surgical planning and do a virtual reduction of my fractures. I can then export my images and put a new image set and overlay them onto my navigation system. And then once I've done my reduction, I can see if I have it where I've kind of created my perfected image set and see where I'm at and make immediate adjustments if necessary. You can do model surgery for more complex cases. This is a case that was, we didn't think was going to make it for a long time. Patient finally stabilized, but it lost a significant amount of bone, had a lot of remodeling, persistent leak. And in this case, we created cutting guides and just placed a custom implant for that patient. And then intraoperative CT scan and imaging, if you have it, is also a nice way, if you don't have navigation, to just confirm that you're happy with your reduction prior to leaving the operating room. Complications can be pretty significant. And a lot of these big open repairs, they can be up to 17 to 20%. This is a patient I saw who had previously been cranialized and was unhappy with the appearance of the forehead. And you can see some pretty obvious deformities. Her 3D scan, she just wasn't reduced appropriately. She has a huge step off, which you can visualize, you can feel. And then the gap that was left inferiorly for the pericranial flap was just way too large and asymmetric, and the burr holes weren't covered. And in this patient, that showed up as a pretty significant deformity for her, requiring a pretty large revision. Hardware complications, persistent or recurrent CSF leak are also possibilities. Really low rates of recurrent CSF leak with transnasal endoscopic repairs. Intracranial infections, either from the fracture or from the surgical approach, meningitis, brain abscess, chronic sinusitis. This is another patient who had severe frontal fractures, didn't think was going to make it, wasn't stable for months, and then showed up and had not had his sinus treated. But you can see persistent deformity, pneumocephalus, and a non-draining sinus. This actually just saw this patient. And then development of mucoceles and mucopioceles, we're really trying to avoid. This is a patient who presented with ptosis and diplopia and had a frontal sinus injury and treatment about 20 years prior, and showed up with a very large mucocele. So really take-home points, the gold standard for diagnosis is CT scan. We're really moving towards a more conservative approach towards the frontal sinus. Not all fractures do require intervention. Severe fractures may still require traditional obliteration or cranialization. However, the trend overall is towards a more minimally invasive approach in maintaining a functional sinus with transnasal endoscopic approaches. and really long-term follow-up for these patients is necessary.
Thank you, Dr. Lihal, for a great overview on the management of frontal sinus fractures. Much appreciated. It's very thorough and a lot of detail there. We had a couple questions that came through that I'd like to pose to you. The first one is, what's your method of assessing or evaluating nasofrontal duct obstruction, whether it be radiographic or clinically or in the operating room?
So definitely radiographic is a primary method of doing it. Certainly, you know, I'm an otolaryngologist, so evaluating it in the operating room is a possibility, but most of my paradigms are involved in just looking at it radiographically. Most of the time, unless it appears severely obstructed, I will just observe them and do delayed treatment of it if necessary. And
delayed as in you manage it endoscopically afterwards?
Correct.
That way.
Mm-hmm. Yeah, unless I'm already going for a large reconstruction, I'll delay my treatment.
Yeah. All right. Next question is, what is your preferred method for obliteration?
So I don't obliterate very often anymore because I've moved more towards, you know, endoscopic repair and more delayed repair. So I haven't obliterated in some time. And I think the question is asking my preferred for obliteration or for actually filling the sinus cavity. I usually use a pericranial flap and would just kind of fold it in.
In terms of these patients that often require neurosurgical intervention as well, is your preferred method to operate at the same time as neurosurgery, or do you do it in a more delayed fashion?
I think if they're going to be taking off the anterior table or performing a large osteotomy and removing the bone flap for some of these severe injuries that need to go more acutely, I'll do it at the same time. Usually those injuries are pretty extensive, and I'd rather just treat them while they're open. They already have a coronal flap down. If they're, you know, treating neurosurgically elsewhere where they don't have to do a coronal incision, then I can follow my normal paradigm and just delay.
Okay. Any difference in treating children that have frontal sinus injuries as opposed to adults in terms of how aggressive you are, I guess, with managing the frontal sinus?
Yeah, again, it depends on the age of the patient. Once they hit around 14, 15, they're basically like little adults, so I treat them very similar. Younger patients, it depends on the degree of pneumatization, but I follow a similar paradigm. We're watching them closely and really making sure that frontal sinus outflow tract remains open. Also, they remodel better than adults. So anterior table fractures, I'm a little bit more conservative in which patients I take to treat because with time, they will often remodel, and defects that I think typically in adults would be more obvious and cosmetically deforming, they are not as apparent in children. So I'm a little bit more conservative.
Yeah, sounds good. Last question before we hand it over to Dr. Gal for his talk is, what's your protocol for follow-up, and how long, in an ideal world, right? We all know it's difficult to follow trauma patients for a very long time, but in an ideal world, what would your follow-up schedule look like?
So I'm usually getting a follow-up scan in 3 to 6 months just to assess the patency of the sinus. And then it depends on if they have an aerated sinus or not. So if they have an aerated sinus, I may, you know, scan in a year, and then if it remains aerated, I will kind of scan just based on symptoms. But for some more of the more severe injuries, I'm following them a little bit more closely, and it really depends on how patent that frontal sinus outflow tract is, if I'm more concerned or less concerned about it. If it's fairly narrow, but I think it's still open, I may follow them a little bit more closely at 3 months and 6 months and then a year out, just to make sure that we're doing an adequate job following them. And then if it opacifies, then I just move right towards endoscopic treatment.
Well, thank you very much for answering those questions, as well as the talk that you gave. Much appreciated, I'm sure, by everyone. I'm going to turn over now to Dr. TJ Gal, give him a brief intro, and then he will give his talk on the management of nasal and NOE fractures. So Dr. Gal is a professor at the Department of Otolaryngology, Head and Neck Surgery at the University of Kentucky in Lexington. He obtained his medical degree from Jefferson Medical College in Philadelphia, followed by residency at South Florida and fellowship at the University of Washington. His practice primarily includes management of head and neck malignancies, as well as microvascular reconstruction and management of maxillofacial trauma. He'll be speaking today again, as I said, on the management of nasal and naso-orbito-ethmoid fractures. So thank you.
Okay, I'd like to thank everybody for being here, as well as thank the AO for putting this all together. As Salam said, we're going to talk about nasal and naso-orbito-ethmoid fractures. This is really two different lectures. They're really two different fracture patterns. They obviously differ in severity and differ in management, but I think if you're really going to dive into naso-orbito-ethmoid fractures, you need a good understanding of nasal fractures because at the end they do go hand in hand. But if you're thinking of a naso-orbito-ethmoid fracture, this is a much bigger fracture than perhaps, say, a nasal fracture. But let's get into nasal fractures here. The nose is the central and most dominant feature of the face. It's a key aesthetic feature along with the eyes and the teeth. That probably, if you look at the spectrum of maxillofacial trauma and maxillofacial training, we really don't spend a lot of time talking about nasal fractures. I guess it's considered easy. Having said that, it's the third most common fracture behind the clavicle and the wrist. You may have a nasal fracture in combination with other craniomaxillofacial injuries, or it may be the only maxillofacial injury in the presence of other orthopedic injuries. They fracture their arms, their hips, their pelvis, and their nose, for example. When we're looking at the nasal anatomy, the nasal bones are relatively small pyramidal structures as part of the nasal anatomy. And this is going to be one of the take-home points, but once you start getting into the frontal process of the maxilla or back into the lacrimal bone, you're dealing with the nasolacrimal sac, and now you're dealing with a naso-orbito-ethmoid fracture. Obviously, the cartilaginous structures also play a role, as we'll see here, but that's the big difference. A nasal bone fracture and a naso-orbito-ethmoid fracture they're going to be two different sites, and they're going to look differently radiographically. Okay. The other thing to remember is when you've got the nasal bone here, it's attached to a number of structures, obviously the cartilaginous septum, perpendicular plate of the ethmoid, as well as the vomer. And it's hard to break one without doing something to the others, and that's often forgotten. And so you'll see a nasal bone fracture, and you'll forget about some of its reliance on the cartilaginous structures. And so what you're actually dealing with is something that looks more like this. And so yes, you have a nasal bone fracture. Again, you do not have a naso-orbito-ethmoid fracture, but you've also got a cartilaginous fracture. You may have actually broken off the nasal spine. And these things are going to make your repair harder or easier, okay? Classification of nasal fractures really depends on the mechanism of injury. It can be unilateral, they can be bilateral, they can be open and splayed, they can be impacted, or they can just be simply green sticked, or they can be all around comminuted and really messed up. This is a severe fracture, but a nasal fracture and not a naso-orbito-ethmoid fracture. History. Usually the mechanism of injury is related to the history. Unfortunately, the history is generally unreliable. There's usually a cover story or something to the sort that you need to sort through. You're going to be looking at symmetry. You need to look in the nose to look at septal injuries, septal hematomas, et cetera. And obviously bleeding, ecchymosis, and so forth is going to be part of the picture. But as you can see in this gentleman here, he's got a dent. Okay, radiographically, again, just like frontal sinus films, we don't do a lot of plain films ourselves. We'll see a lot of them in the emergency department setting. They're nonspecific, and really old fractures of the nose look like new fractures of the nose, so they really aren't necessary, and they're not going to change your management. The decision to operate is going to be more on appearance than x-ray. CT is certainly going to give you a better definition of your fractures. It also allows you to look at the septum, but is really unnecessary when it's just the suspicion of an isolated nasal injury. Somebody comes in and looks like they need a nasal reduction. I don't necessarily image them, although they have frequently appeared before we have. So again, here's your plain film. This is a nose that's been broken at some point. We don't really know. We don't know what it looks like clinically. It could be shattered but straight. It could be minimally shattered but really deviated. And so really it's almost more important to look at the patient than the x-ray. Same sort of thing here. It's actually fractured off the nasal frontal process there. Not a naso-orbito-ethmoid fracture. But the other issue is we don't really know. There's a prominent cartilaginous component, so we're not really going to know what this nose looks like. You get a little bit better idea radiographically, and these are relatively bad nasal fractures. They would be classified as comminuted nasal fractures, but the important thing to note is if you look at the frontal process of the maxilla, and specifically the nasolacrimal duct, it is completely intact. So this, by definition, is a nasal fracture, not a naso-orbito-ethmoid fracture. If the fracture has not gone through the nasolacrimal duct, it's a nasal fracture. That's one of the big take-home points because they are managed completely differently. The other advantage to CT is, again, you can look at the nasal septum. You can see this is really knocked out, and as far as nasal obstruction and support of your external nose, failing to address this is going to make your life harder. So what do we do about nasal fractures? It's really a question of if we're going to do anything, it's going to be some sort of reduction, and then the issue is whether it's a closed reduction or an open reduction. Closed reductions need to be done fairly acutely, as we'll get into shortly. As far as an open reduction, that can be done in the acute setting as well, usually in the setting of additional soft tissue trauma, or it can be a delayed rhinoplasty. So a closed reduction is a blunt reduction. There is no exposure of the fractures. There's no incisions. There's no fixation. It can be done under local. More of a fan of a general anesthetic, but nonetheless, it can be done under local, and it has been done under local. It's really a battle of swelling versus healing. It's hard to really tell whether they need to be done because of the swelling, but we don't want to wait too long because those bone fragments will start to heal together where they are. And so generally about 5 to 7 days after the injury winds up being sort of the optimal window. But if you see they need to be reduced right away, and you can, that's fine. I just wouldn't, beyond 3 weeks, those bones are fixed. The advantage of a closed reduction is the high level of patient satisfaction. You get a perfect result as far as, depending on how you define perfect, in about 20 to 30% of patients. The flip side of that is you really only wind up doing a revision in about 15% of patients, and those would be delayed rhinoplasties. So as far as a closed reduction, you're talking about instrumentation that's inserted into the nose of, for example, a Boy's elevator, also known as a butter knife. Ash forceps or Walsham forceps, all of which are designed to mobilize the nasal complex and or straighten the septum, disimpact things if necessary. So again, the advantages of a closed reduction is it's simple, it's quick, it's effective, and you really don't burn any bridges if it's not right and you want to revise it later with a rhinoplasty. It's basically a healed acute fracture. You've just moved it to a more favorable position in the hopes that you don't need to revise it. So again, it's imprecise. It's not as good in the absence of splinting at overcoming the forces of the cartilaginous nose. And so if that's really been fractured or really displaced, you may wind up needing to be more aggressive with something, whether that is in the acute or delayed setting. And there is, again, that window of opportunity. frequently show up to your clinic about 5 days out, and then you're trying to scramble to get them into the operating room within the next couple of days. Because you really like to do them within 5 to 7 days if possible. An open reduction implies surgery. It implies either an incision or an approach through a concurrent laceration. It implies some degree of rigid fixation, whether that's suture or some sort of plating. You can certainly perform your septoplasty at that time. And this can be, again, primary or delayed, but generally if there's a laceration, that's when you're going to do your open reduction. The advantages is it allows you to deal with your avulsive injuries. The severely comminuted nose is not generally amenable to a closed reduction per se. It's like scrambling. You've got a big pile of rocks and you're trying to straighten it out and make it into a wall. It can be sometimes difficult. You've got a large overlying laceration. You've certainly got that opportunity. If you're dealing with telecanthus, now again, that's a bit of a misnomer there, because if you've got telecanthus, you've probably got an NOE fracture. The disadvantages is scarring if it's an incision versus a laceration, and certainly there is some degree of devitalization of tissue. So again, most of these wind up being done through the lacerations that are there. If you need to extend them, try to do it along appropriate subunit incisions. I advise against the open sky or suprabrow incision certainly for a open reduction of a nasal fracture, but in general. The bicoronal, I wouldn't do a bicoronal just for a nasal fracture. It's a bit of a long run for a short slide, but if there's other injuries, certainly good access to the upper third of the nose, as well as placement of bone grafts if necessary. But an open rhinoplasty is probably your best. So now let's get into naso-orbito-ethmoid fractures. This is not just a nasal fracture. So again, NOE is the common nomenclature. It's a naso-orbito-ethmoid fracture. It's not a naso-ethmoid fracture because of the ethmoid component. It not only involves the nasal bones, but it involves the medial orbit and ethmoid complex. It involves the frontal bone as well as the frontal process of the maxilla and probably the orbital rim in most circumstances. Structural unit, it brain up where it belongs. It keeps the eyes at the appropriate distance. It protects the frontal sinus outflow tract. It protects the lacrimal system as well as keeps the nasal cavity roof intact. As far as anatomy, just like the middle third of the face, it's about buttresses. You're talking about vertical buttresses of the frontonasal and nasomaxillary buttresses. You've got the horizontal buttresses of the rim, both superiorly and inferiorly. And all of this is in some degree designed to address the medial canthus, which is the crux of NOE anatomy. And so if you're dealing with the medial canthal ligaments, again, if you look at this inferior diagram, it attaches posterior to the nasal bones. It actually comes in around the lacrimal crest, just slightly anterior to it. And that's important as far as how you're putting this segment together. It's a very delicate soft tissue. When it's disrupted, you get what's known as telecanthus. And so normal orbital anatomy is such that the distance from the mid-pupillary line to the midline should be symmetrical, or the distance from the mid-pupillary line to the other mid-pupillary line should be twice the distance between the canthi. Put another way is the rule of thirds. In other words, canthus to canthus should be the same as canthus to canthus on the other side, which should be the same as the intercanthal distance. As you can see below, that's a naso-orbito-ethmoid fracture. Okay, that widened distance there. There's some rounding of the orbits. You can see this more pronounced there, where this distance is much wider, results in some droop of the lid. This is that same patient later, and part of that is from the incision, but this distance is wide and this is rounded. And so you get shortening of the palpebral fissure, okay? Pardon the cadaver photos, but just to show you the bowstring test, if you pull laterally on the orbit here, nothing really happens other than your lids kind of tighten like a bow. If this is mobile, this all comes with it. Put another way, if you're doing it bimanually and you have something intranasally and then you press on the canthus, it should be mobile, okay, if it's fractured. Otherwise, it's a stable situation, okay? The Markowitz and Manson classification really is just designed to delineate the severity of the fracture. So a type 1 fracture really just involves a larger bony segment, if you will, that's fractured off of the frontal process, nasal bone, and orbital rim, but the canthus is attached to a large segment. So technically, in theory, if you get this segment reduced, your canthus is intact. Okay. Type 2 is a little bit more comminution, but in theory, the central fragment has an intact medial canthal tendon on it. Type 3s being there's severe disruption and this canthal tendon is disrupted completely. Now, just like all fractures, whether it's the mandible, whether it's the frontal sinus, or in these cases, we're always taking off the soft tissues and periosteum to expose the fracture so we can plate them. Now, the concern here is you really want to be careful because a lot of times you've got something that looks more like this and you disrupt that and you're cleaning off all the soft tissue to get these bony fragments removed and you've made one of these into this. And that's what I personally refer to as the Markowitz 2.5. That's the one that was a 2 that I made a 3 trying to get all the bone in place. So if you can find this tendon, you'll get your answer. And obviously some of that you can see on CT preoperatively, okay? So the key to this whole reduction is central fragment and medial canthal tendon reduction. It's challenging. It's difficult. And if you don't get it right, it's hard to make it go away permanently. And that leaves you with that just not right look of the face. So again, stabilization and repair of the medial canthal area, reconstitution of the skeletal framework in this area. That includes the orbit, frontal sinus, appropriate nasal support, and anything else that's broken along with it. And then once you're all done, you need to resuspend that soft tissue repair. You get that bone of the naso-orbito-ethmoid complex together and you don't address the soft tissue, you can get what's called pseudo-telecanthus, which means that you've done a good repair, but they still look a little bit wide. Okay. So the goal of treatment is restoration of the intercanthal distance by the repositioning of the bone and by the repositioning of the canthus, really, which implies repositioning of the bone. Now, the one thing, obviously, the more complex the fracture, the more complex the plating. But the one thing I want you to look at is this curve of this plate here, and as it goes across, this is the plate. This is not a straight plate, okay? This is also not on the nasal bone, okay? This is back here, and you can secure things to the plate. If you need to secure the canthal tendon to this plate, but if you don't get these pinched in, you're gonna be wide, okay? Regardless of how severe your fracture is, okay? So type 1 fractures, you're gonna need to get to these from below, so you need a vestibular incision, you need certainly an eyelid incision to get to this, and AO says, consider a coronal approach. I really think unless you have the perfect laceration, that you really can't appropriately address this fragment up here without a bicoronal incision. And you plate what you need to plate, but you're at a minimum going to have to plate this and this, but you're probably going to have to get something on here to stabilize that as well. More severe fractures, again, the other thing to note is that there are other fractures associated with it. So you can't reduce your nasofrontal process until you've addressed the frontal sinus fracture, okay? This one's certainly going to get a bicoronal. This is not an endoscopic frontal sinus repair, although I enjoyed the talk and I'm a big fan, but not this one, because you have to restore this in order to attach it to this, okay? And once you get this stable bone laterally stabilized, you can work your way in from the rim, and this is going to start to look a little bit more normal, and you can find the soft tissue tendon attachments, but this is one where you may need transnasal wiring or secure it appropriately to your plate. And so type 3 is, well, we don't know, but there's a good chance that one of these segments has a tendon attached to it. So if you can find it, once you've reduced this, get your rim and your nasal frontal process. So the smaller you make this gap by stabilizing these segments, the better off you are. And then you can deal with the canthal tendon, either with transnasal wiring or some sort of barb or securing it to the plate. Okay, so just to show you, now I wouldn't recommend this approach, but this is a cadaver, but you can see the tendon, it's not on the nasal bone. Okay, if you secure it to the nasal bone, they're gonna look funny. It's back here, it's back by the lacrimal bone. It's almost at the junction of the lacrimal bone and the frontal process of the maxilla. Okay, but it's posterior. It's really hard to get it to posterior. Okay, and so once you've got your segments reduced, here's a bicoronal incision and here's the nasofrontal process, but you've got these segments, and then you can pass your wires through and grab the other canthus and bring it back through. It is technically hard, okay? You sometimes are better off because the holes you drill for the wires are also about the same size as the holes you drill for the plates and screws, and so it may be that you secure the tendon on the same side, okay? But you can't over tighten it, and you really need to make sure you get these segment, this particular segment, I'll show you more, as in as you can. Okay, so again, conceptually, this is what we're talking about with transnasal wiring, and so you can certainly see this is going to be a challenge, and it also implies that there's something stable over here to wire it to. Is you've got that segment with the canthal tendon in it, you're going to throw your wire through it, then you're going to get it to the right spot on the other side, bring it back out, and secure that wire so you've got a loop across here. This is what it's supposed to look like radiographically. But again, you've got these fractured segments, and I showed this. This is not an optimally wired. I would really try to get these in, and I would try to get these plates a little bit more posteriorly, because then you can use them to address your canthal tendons to some degree. But just envision drilling a hole in the back of these and passing that wire back and forth. It is a hard approach to manage. Okay, and here's the issue: is that you're gonna pass these wires, but the canthus is really centered around the medial canthal tendon, and so really the optimal place for your wiring is back here, and that is really hard with these eyeballs in the way. Okay, if the eyeball's gone, it's easy. But if you get your plate up in the front around just anterior to the canthal tendon, you can orient it and bend it in such a way that it reproduces this effect without trying to sew this, because this is all shattered as well, let's face it. So, but if you can get your plate on here, even if there's no bone, you get your plate on here and then you can secure the tendon to the plate, that solves a little bit of this difficulty. So it's just one other thing. And again, try not to strip off a tendon that wasn't avulsed from the bone if you can help it. Okay. Shown another way, again, this is just sort of a demonstrative laceration, is you've got these plates, again, securing the nasofrontal process, but you've got these plates, and look at that, that is tightly curved in. If you don't account for that, you're going to look wide. The canthus is actually going to be even posterior, at the minimum at the very back end of that plate. But if you can secure that bone that the tendon is attached to this segment, you're going to be in better shape. Because getting a wire across here is, again, it's admittedly challenging. Okay, your bicoronal, or in this case, it's a large laceration, is going to be the best time to do your open reduction of your nasal fracture for dorsal nasal support. This is a rib graft. And that's going to be the difference between a nice straight nasal profile and your saddle nose deformity. Okay. Bolsters, they prevent hematomas, they reduce edema, and they help avoid what's called pseudotelecanthus, which is where you get the bony reduction actually right, but it still looks a little wrong, and that's just because of delayed edema. You can sew bolsters on. I'll usually actually use just a Denver splint or aquaplast or something to that effect, but this is what your bolsters look like. Okay. Now, if you're doing a rhinoplasty, you're probably going to seat your bolster right about here, but what I'll do is I'll actually just ride it up into this frontal recess and pinch it very tight, and that just helps. You're going to need some internal splinting, probably some Doyle splints or something. Don't sew these too tight because you can necrose the skin, and now you've got an almost irreparable soft tissue injury. But this is how most naso-orbito-ethmoid fractures appear. This lady fell off an ATV and got hit with the toolbox that was in the back of it. And so obviously there's a few other injuries, but if you're focusing on the naso-orbito-ethmoid, on the right side, she probably has a type 1. There's a fracture off the frontal process there, in the orbital rim. This side is at least a 2, okay? And if you look radiographically, it's separated off of the nasofrontal process. You can see how wide this is. The other issue is look at the nasolacrimal system. They're both fractured. So again, this is a naso-orbito-ethmoid. This is not just a nasal fracture, okay? And that's a very important thing. And there's also obviously a little bit of cribriform plate involvement of the ethmoid complex. Once we got Humpty Dumpty back together again, you can see we secured the nasal process to the frontal bone, and then you've got these narrowed in plates shown in close-up, but if you look at the shadow of the orbital rim, we've got this in pretty okay position, and that's just secured with plates. We made sure the tendons were reduced, and she actually did reasonably well. So the take-home points, again, the one thing I really want you to take home from this is that if you can't tell for sure, because something's very comminuted, a naso-orbito-ethmoid fracture goes through the nasolacrimal duct. If it doesn't, it's a nasal fracture. Okay? You really can't, but should always try to overcorrect the medial canthal tendon repair. If you need wiring, you need wiring. The key is to reduce the bone, and the tendon is generally secured to one of those fragments somewhere. And you can secure that to the hardware, you can wire it, you can splint it. You generally need to do all of those sorts of things. Correcting the nasal deformity with the naso-orbito-ethmoid fracture is key. And primary naso-orbito-ethmoid fracture repair is the best, and really it's probably your only chance of getting this right. I'm going to guess there's a bunch of questions.
All right, thanks, Dr. Gallo. It's a great talk on nasal and NOE fractures. You definitely do have a lot of questions. Some of them were fielded during the talk, but I'll try to summarize a couple of them. The first one someone asked is, in terms of doing closed reduction of a nasal fracture under local anesthesia, how do you administer that local anesthesia? What type of blocks do you give? What do you use to infiltrate?
I will infiltrate the nose. I'll take some pledgets that are soaked in Afrin for decongestion and some 4% lidocaine, and then I will do a nasal block with local anesthesia, both to the columella as well as along the lateral aspect of the nose. There's no real good way to make it a pain-free and pleasurable experience.
Yeah.
So it's really not my preference. Unless there's an absolute reason not to, or the patient just doesn't want it done in surgery, I generally prefer to do them under general anesthesia or at least some propofol sedation or something.
Yeah. In terms of the medial canthal tendon and how that's managed, there were a lot of questions about, one, how to locate it. You described how you fixate it, and opposed to the transnasal wiring, you prefer putting a plate on. But especially in secondary reconstruction or repairs, that can be kind of challenging. So what tips or tricks would you have for locating and fixating or
again, as the last statement of the talk is that your best shot is the first shot. So if you specialize in secondary telecanthus repair, God love you. But as far as finding that fragment the first time in, grab it from the outside. In other words, you're going to try to grab it from out here and do that bowstring test, and it will generally bring it to you, no matter how small. But it may be that you can, if you can take that piece and throw a stitch into it and then drill a hole into a nearby piece of bone and suture it to that, and then get that plated to something. I mean, even if it's something like that, if you're able to find it and plate it, that's one thing. But sometimes it's a suture to a piece of bone that you can throw a screw in and hook it to a stable piece of bone. And then really it's just that curve that you're putting those plates on is key. Mm-hmm. And as they come in from the frontal process, you really want them to go down. You want them not only as you're going down, but you're going in as you pinch it in. They go this way. They don't go this way. Okay, I don't know if I'm able to show that well, but they go in this way. They don't go down that way, if you're able to see that.
As you
you will generally find the tendon by grabbing the canthus externally outside of your incisions. If you go in to your soft tissues through your incisions and find it, you probably just avulsed it.
Yeah. Okay. I'll ask just two more questions for the sake of time. This question might be a little bit outside the scope of the talk, but in terms of sequencing, if you have a ZMC, an arch fracture, and an NOE, so let's just say a panfacial, for example, what's your preference, to start with the NOE or start outside? What do you prefer to do?
In my opinion, you're dealing with panfacial fractures. Once you've exposed everything, you're working from stable to unstable. And so starting with the NOE, in my opinion, is kind of like starting to build a bridge in the middle of the river. You're not going to do that. You're going to start from land. And now it may be that one of your first moves is to stabilize the nasal frontal bone, but that's going to want to stabilize somewhere. You may be off a little bit. If you're off to the side and then you start plating into this, it's not going to line up. And so it may be that the best way to get this, even this simple thing, although this bone is stable, is to work your way in from this way. And so I'll try to get the architecture as close to this process as possible, and then work your way down from the frontal sinus. And once you've got that oriented, really, I think it's almost your last move.
Okay. I'll ask one more question, and then I think we're out of time. But in terms of suspending a medial canthus tendon, if you're not using a wire, what suture do you prefer to use?
it's a fine line between something sturdy and something that will eventually become infected and exposed. And so I'll tend to use some sort of PDS or something that's a little bit more durable than a Vicryl or a chromic, but not something that's eventually just going to loosen and get pussed out like a you know, a Prolene or something like that. But that's my preference.
All right, well, thank you both. Thank you for everyone that joined us, and thanks for Dr. Gal and Dr. Lighthall for the wonderful lectures. We'll be sending out in about 24 hours just a survey to complete, I believe, to get your CME credits. So thank you everyone for joining us. Much appreciated.
Thank you.